Welcome to the wonderful world of wellness with Dr. Andy Mencia. This medical program heard from 7 to 7:30 each Saturday right here on WSBR 740 AM is brought to you by the Adult and Geriatric Center under the medical direction of geriatrician Dr. Andy Mencia.
Well, good morning.
Good morning, Dr. Mencia. It's
good
so
morning,
nice.
Dr. Mai.
Hey, Dr. Mencia, how are you?
He's back. He is back.
Yeah, he's back. And I want to just say it's M-A-J. It's an unusual name.
Yes, but I have to write it down. Write it
M-A-J.
down. It's M-A-J, but you pronounce Dr. Mai.
My M-A-J. So tell us a little bit about where did you get that name?
You know what? I actually, it's funny.
Where did you find it?
Yeah, you just did that to be cute, right?
I'll tell you what happened to me, but that's actually a Polish name, and M-A-J is the way we spell the month of May. So in the U.S., you spell it M-A-Y, but in Poland, it's M-A-J, and you say it Mai, or, May, which is the month of May. And that's just that's just the way we pronounce the name. What's interesting about that is when I was actually interviewing for residency after my medical school, I walked into this room, and this guy looked at me like, wait a second, who are you? And I knew he was confused because I've seen this look before. And I said, yeah, you're probably thinking I'm Asian or Indian. And he kind of turned red, and and obviously that's what he was thinking. And I said, well, I'm already here. We might as well just do the interview, right? And it was pretty funny. The guy ended up laughing, and so did I. But
it does take people. It is. I'm sure when you say your name, it takes. They say, oh, and then they have to ask you a little bit more about it, right?
Exactly.
But, okay, so now we got that. But Dr. Mencia is funny. He brings very, very unusual guests here. He brings very beautiful women, and then he brings very
handsome guys like Dr. Mai.
Interesting people who are doing. And it's funny because there's never a jealousy with Dr. Mencia. He finds the best people he can find, and he brings them into his
my circle.
Well, yeah, I was going to use a different his lair.
Inner circle. Once you're in, you can't escape.
And then one helps the other, and it's an unusual thing to see.
Yeah.
And I'm always really happy that he wants to share all these people with his patients. Yeah. Where'd that idea come from, Dr. Mencia?
Well, when I studied I love marketing, and I study a lot of medical marketing and how many lawsuits are out there. And the background of lawsuits is not because physicians and nurses are bad. It's usually the mistakes that we make when we sometimes become negligent with our mistakes. And going to nursing home, I will see, let's say, a podiatrist that will go and look at the patient feet and will put in their note, this patient need vascular study, let's say. It's the podiatry. You're supposed to cut nails, take the calluses off, and walk away. And nobody read the note. Then the person ends up losing an extremity or a toes, and there's a lawsuit. And the lawyer say, look, there was a note right here by one of your consultants stating that you should have looked into the vascular part of this individual to prevent the loss of an extremity. And I say, we need to communicate better. So I started saying, well, if we work together, because in the hospital, we go to the hospital and we see patients, but that does not mean we are communicating. So I go to the hospital, let's say, 6 o'clock in the morning and see my patient. Dr. Mai come in at 11 o'clock in the morning and see the same patient. And unless we communicate, there's a note that he will dictate. It will not be there when I'm seeing the patient. My note that I dictated, he won't see my note. So there is not the actual communication. And a lot of time, let's say, Dr. Ram, the diabetic specialist, the endocrinologist, he will see a patient and he will come in the hallway and say, okay, let's talk about this patient. This is what's going on. This is what I want to do. We have to control the sugar better. And Dr. Mai will be seeing a patient, and we work together, and we talk to each other. We discuss cases. So all the consultants, the ophthalmologists, the dermatologists, And I tell you, I just clear Lillian, one of my patients, for surgery because she has this spot on her cheek, on her face. And, it looked brownish, a little dark dots here and there. And she said, I have this for life. I said, well, it's bigger. He said, it's not bigger, but it's thicker. I said, I want the dermatologist to take a biopsy for me. And it was melanoma. Mm-hmm. So we moved so fast with this woman that she's going now, I think Tuesday this week, to have the plastic surgeon do surgery on her, do more surgery.
Is that the Mo that they said, Mo or something?
Right, the more surgery, right. Surgery. So she's going, so we move really fast. We have a patient that came in and she said, I get this little, and I hate this, proton pump inhibitor. Everybody want to be on proton. It's like
buying what?
On proton pump inhibitor. The omeprazole and the Nexium and, all those medications.
Why do they love that. Why?
Because everybody complain about everything. Everybody think they have GERD. Oh, I have GERD, I have acidity.
And you hear it on the commercials all the time. Ask your doctor about Nexium. Ask your doctor. And so patients are coming to ask.
And this is horrible. This proton pump inhibitor, they are horrible for the patient, long-term use. Now, if you have an inflammation, it's okay to use it for a short period of time. But some people get put on and they stay for life on this medication. Like if it's a thyroid replacement, it's not. It will damage your thyroid. It will damage your bones. But people do it. So she came in with this little gastric, and she said, I heard in the commercial that take Nexium. So I said, lie down, let me check your belly. And she has this lump on the right upper quadrant. And I say, Now she has an HMO that I don't take. I take for medical, but, it's one of those HMO that they save money by not doing tests on the patient. I said, let me do an ultrasound. I want to take a glance at this. And in the tail of her pancreas, she had a tumor.
Oh, my gosh.
I said, look, let me print the preliminary report. Let me call my surgeon to see you. And we called from the office. I said, I want you to see this lady ASAP. She got seen the same day. We agreed that this had to be a tumor. So we went through the clearance, and just to make sure we are not operating on something forced, but, it's real. Then we went ahead and ordered the CAT scan, but the process for medical clearance was already ongoing. And the process for making the diagnosis with imaging, then we add that toward the end. But everything was done, and I saw that patient last week, and she's doing very well, thank God, because we were able to remove that without doing major surgery. And everybody knows pancreatic cancer is a killer. So, going back to your question,
the question was,
having Dr. Mai there, I am so pleased having him there, because my feedback is the patient. When they come to me and they say, Dr. Mencia, Dr. Mai saw me, he took care of my vein, I feel so much better. My leg always was feeling so tired. And I thought it was my heart. I thought it was my hip. And I kept, just complaining about my leg. And now that Dr. Mai saw me, now I feel like a new person because I can walk now.
Well, that's what I had said to Dr. Mai, in a sense. What is all this about the veins? And when did it start that it became a problem, a medical problem? There must be some history.
The origin of venous disease started as a cosmetic issue. Patients see something, they go to the doctor, and back, hundreds, probably not even hundreds years ago, probably about 50 years ago, we're still doing stripping. Basic stripping is you come in, you have these large varicose veins on your legs. Somebody sees them, they take you to the operating table in the hospital, put you under general anesthesia, make these incisions. They're about 6 inches, maybe even bigger. Pull all the veins out. And, to be honest with you, I was lucky enough to see one of these. It's just an excruciating, just watching one of these is just excruciating. So I went, I do a lot of consulting, actually not only in the country, but also outside of the country. And I went on a trip to China, one of the biggest cities in China, Shanghai, enormous place. And I met about, I'd say 7 or 8 hospitals in a span of 4 or 5 days. Hospital, giving lectures, looking what they do. And surprisingly, every single place that I went to is doing stripping. And I thought to myself, this is 2000, 2015, I think, 2014, 15. And I just sat down and started asking them questions. They were asking me questions because I presented what I do, kind of, how we're treating. And they were surprised. Patients are walking in at 10 a.m., at 10:30 a.m. They are out and going to work, going shopping, doing whatever. And I said, how long do the patients remain here? And they said, well, they come on Monday, and usually they're released the following Monday, so 6 or 7 days.
Wow.
And I'm like, there's 6 or 7 days in the hospital. And like, yeah. And I'm like,
that's expensive.
I guess I was surgery today. So I went in and I watched this, and they literally cut people's legs open, take the veins out. As you can imagine, there's, your venous system handles about 75% of your blood's in the venous system, but only 25% is arterial. So it's a high volume system. These people are bleeding all over the place. I mean, the whole floor, everywhere. People holding pressure. Then you got to wrap them up. A lot of them get transfusions. And you think to yourself, like, we do this in a matter of a couple of small injections. Patients walk in and out. And then, I realized that it wasn't the physicians who are incapable of doing it. Because they were easily, you can easily teach individuals to become competent and do the surgeries that we do. But it's the system. The system dictates that over there, only removal by stripping is going to be performed, not endovenous anything.
And you didn't stay there long enough to look at all the complications.
Oh, the complications, I heard.
All the infections and stuff like that. We've seen that in Mount Sinai, New York, the complication of vein stripping. It can be horrible.
So then I said, okay, get me somebody who's doing what I'm doing. And it took literally 2 days to find somebody. And I actually ended up finding 4 individuals. So there's, I think, only 5 individuals in the entire city of Shanghai, which you have to imagine it's 5 times the size of New York City. And these individuals are doing these procedures, but they're all in private hospitals. So that means you're paying out of pocket or you have private insurance. So everybody else is under this stripping regime, if you will. Mm-hmm. And it's just, I don't see that. We don't see this at all. Right. Once in a while in the U.S., and, you think you see these patients, but they've had it done 10, 20 years, 30 years ago. I have patients that sometimes come back with these huge scars, and I know exactly what's happened to them, And so it's a completely different world of what we do and what's done over there and what we used to do.
Okay, so now what you do there probably are very minimal scars, if any.
When I tell patients they're going to be left with a little brown dot at most, even when we're done with any kind of procedure that I do, there's no stitching. We don't stitch people up because it's just we're going right into the vein through a needle. It's a special technique. And when the patient comes out, we just put a Band-Aid on where we entered. No stitches, just a Band-Aid and a compression sock, and they walk out. So
is there a chemical or something that's going in to kill that?
There's different ways of doing it, either doing by heat, laser, or radio frequency. There's certain chemicals. You can use sclerosants. And like I said, we just go into that vein through needles and do all our work and then come out of there like nothing happened.
Yeah. And so the vein is so obvious that you can see it as you're going in if it's a large vein.
Yeah, basically we can use ultrasound. So we have eyes inside you. Through ultrasound, we basically see everything that's happening real time, give you the anesthetic where it needs to be. And so, if you're doing this, I've done ablations, over 7,000 of these ablations, probably treated over 20,000 some patients. And the minimal risk, you asked me this morning what hospital did I practice out of, and I think that's something I gave up years ago. I don't think
AGI.
I've seen the inside of it.
AGI hospital.
That's what he was saying, that he doesn't go to, which is better to keep out of the hospital.
I say, if you're not sick, don't go to the hospital. Second, Dr. Mencia's what he said, and that is miscommunication. You end up in a large institution, and there's going to be a lot of miscommunication. Interestingly enough, I get a report from my malpractice insurance company every year, and I demand it. I want to know what's going on in the market. And they give me information about every case they defended that year based on specialty. And they look at every piece of information and they present it to you. And the number one thing for malpractice lawsuits is miscommunication. Mm-hmm. And I think part of it is the physician, hospital physician, nurse to physician, kind of triangle.
To physician, right?
Exactly. Mm-hmm. But the other part is patients don't follow up. If you had a test done, follow up with your physician. I think in part, we have to tell the patients, look, you're responsible for your own health. It's not only the physician, but you're also responsible. It's your health.
It's your health.
If you had a procedure done, if you had a biopsy, don't you want the results of that?
I'm going to jump in there, and you need to have an advocate because you can't just, too much to remember. Bring someone with you. And that's another whole story that we're going to talk about another time. But exactly. I want to go back then to the vein. So tell me about the stockings. So when they're finished, do you want them to wear stockings?
I do. When they walk out of the office, I usually have them in stockings for a couple of days. Nothing crazy. I'm not going to put you in 3 months, just a couple of days, depending on what you've had done. And a lot of patients will report that they feel better when they wear those. They have like this support and they feel like things are feeling okay. And that's it. I mean, after we're done with everything, the stockings, I want my patients to be stocking free unless there's special circumstances. Certain patients have, severe disease where they're going to have to be on stockings for a longer time. But as much as possible, I try to get them off of the stockings.
And now I want to talk about men because we were just having a conversation. And so I asked Dr. Mai, what about men? Who needs this procedure more, men or women? So
interestingly enough, when we look at the data about vein disease happens in about 55% of women as compared to men. So 55 men, 45 women. But the venous disease that I see in terms of severity is much, much, much more severe in men than it is in women. And that's because women come in when there's a tiny little vein. Right. Doctor, it's right there. Can you see it?
Yeah.
And usually I got a magnifying glass. I turn on the lights, ask my assistant, I'm like, I don't see this vein at all. But they're already there. They're already in the office. Men don't show up for years. Men will suffer through disease and they say, no, my legs are just heavy. I've been working construction all day.
Yeah.
No. You work construction today, you should still be okay. And they come in and they have these discolorations or skin breakdown, ulcers, large varicosities. And I've never seen someone disease that bad on women. I've never seen varicosities the size of my fist on women.
I saw a new patient yesterday. He was a black man. And his daughter is a nurse, so he's there with his daughter. And I say, I want him to get the ultrasound of the vein so we can study his vein and put him in a consultation with Dr. Mai. And the daughter said, he never complained about his leg. I said, well, did you ever ask him? I said, well, you didn't ask him either. I said, when we examine a patient, from the moment you walk in, you come walking down the hallways, I'm already examining you. So I examined your father when he was getting weight and walking this way with his shorts. When he sat down on the exam table, I see the vein just popping all over. So let's ask him some questions. So, of course, he came in, all in with venous insufficiency. And no ulcer, nothing like that, but losing his hair or the leg. And he said, yeah, I used to have a lot of hair. Now I have no hair from my knee down. And
excuse me, what does that have to do with it?
We're going to go into the
signs
and symptoms. Yeah.
I was saying he just didn't shave.
To women, it's like, oh, that's great.
I shaved to see the doctor. So just by checking the legs, and that's what I want to go into. For those people, because the show that Anita has called Pencil Talk, what would be people at home? What are the signs and symptoms? Signs meaning things that we can look at home, and symptoms are things that we feel that prompt us to come and see Dr. Mai. So what are the signs and symptoms?
Exactly. So, perfect. Signs and symptoms are something to talk about. One of the signs is hair loss. If you have hair loss, that's definitely a sign. Below the knee hair loss, this sign of venous disease or some kind of circulatory problem. Starting from the easiest one or the smallest one, spider veins. Some spider veins are going to be cosmetic as we age. Some spider veins are going to be a result of some venous hypertension. And everything we talk about here is venous hypertension. What's venous hypertension? Venous hypertension is abnormal pressures in your veins. So when you go to the doctor's office, you go see Dr. Mencia, first thing he does, he checks your blood pressure. So that's the arterial blood pressure. I work on the other side. I work on the venous side. So venous blood pressure is basically what causes legs. So number one is going to be spider veins. Number two, larger veins, varicosities. So varicose veins. When you have skin discolorations, a lot of patients come to me and I say, look, right above your ankle, below your knee, but above your ankle on the shin, you have a little bit of brown pigmentation, little brown dots over there. And the patients say, oh yeah, because it's Florida and I wear shorts. And I said, okay, so you're telling me that your shorts, you wear two just below the knee. And they're like, no, doctor, come on. I wear the ones right to the mid-thigh. And I'm like, so how come your knee's not discolored? And then here comes the wheel. It starts spinning and they start thinking, well, maybe you're right. Maybe there is something going on. Why isn't it? And we start talking about, how venous disease happens, what's going on, and why they're getting this discoloration. A lot of patients will have redness of the legs. A lot of times you'll end up in the ER or emergency room or urgent care, and they get diagnosed with cellulitis, right? Mm-hmm. So what they're having is redness from the knee to the ankle on both legs. So true cellulitis, infectious cellulitis, would be very unlikely to happen in both legs. That means, you took a hammer or something, you hit yourself, broke the skin, got an infection, and took a hammer on the other leg, smacked yourself, or those legs somehow mated together, and it's so impossible.
Right.
So a lot of times you're not having an infection. A lot of patients will get checked for blood clots. Again, you don't have a blood clot. What you have is abnormal pressure in the venous system, which is causing this inflammatory, raging inflammation, and that's the redness. It's inflammatory cellulitis due to venous hypertension. So I see a lot of that. I actually have a lot of patients who come in or referred to me, says I went to the ER and they gave me antibiotics and they scanned me for blood clots and they didn't find anything. And I said, well, did anybody ever put you on compression socks? No. Here, put these on. And patients feel great the next day and the redness starts going away because you can rid of those pressures. So redness. Another thing is ulcerations. If you have skin breakdown, ulcers on the inside of the ankle, or just thickening of the skin, or skin that becomes brown and thick to the touch. Okay, so those are your most common signs. Okay? Now symptoms there's a wide variety of symptoms. A lot of patients will, like Dr. Mencia says, a lot of patients say, "Well, I don't have any symptoms. I think my legs feel great," and that's because venous disease doesn't happen from today to tomorrow. You know, if you knock off an artery, you're going to start losing toes. Right, it happens immediately. Venous disease is very progressive, so you could have a venous disease for 5 years, 10 years, 15 years. And it's so gradual. Every day it gets worse and worse and worse and worse. But you don't feel it because you feel, oh, I'm just getting older and my legs are supposed to feel like that. So what I do is a very inexpensive man's test, if you will. They come to office, we put them on compression socks. And I say, look, wear these for 1 day, for 5 days, for a week, whatever it is. And then come back and see me, but promise me you're going to wear them. And the patients wear them and they come back and they say, look, I didn't think anything was wrong. But when I wear these socks, something's going on because I feel great.
Excuse me, tell me what the socks are doing.
What the socks are doing is actually compressing that vein. So if the vein's not working, let's talk about how the veins work. Veins have little valves. The little valves are one-way valves. They're open and close. And the vein opens, blood goes up, and the valve will close. And that's all the way up your leg. But when the valves break, instead of opening and closing, they start flopping around. Blood ends up going down the wrong direction. And that causes abnormal flow in the wrong direction, causes those venous pressures. And that's what causes venous hypertension. Okay? When we put somebody in compression socks, the compression actually closes that vein, maybe not entirely, but to a point where that flow is either improved through those valves or it doesn't use those veins, goes to the healthier veins deeper inside. So it's almost like a treatment, but you have to wear those compression socks all the time, right? So in hot place like Florida, patients can't sometimes have osteoarthritis, can't put them on. It's very difficult. But if I can get patients to wear them, they come back and they usually report, most of the time, almost all the time. Say, my legs feel great. What are these magical socks?
Magical socks.
Magical socks.
Wouldn't you prefer, though, to do the venous, take care of it, and then have them after? But what you're hiding is the problem, in a sense, aren't you?
You know what? So the insurance companies, so now we're going to jump a little bit, but the insurance companies always recommended that, we try them to see what's going on, which I agree with. I think that I put people in compression socks to make sure this is venous disease. If you come back and say, I still have that ankle pain, the compression socks didn't fix it, you know what? We're not dealing with venous disease. There's something else going on.
There's something else to look for.
Or there's maybe a second problem, we're partially addressing. So let's go through the symptoms. So patients have leg pain. That's most common. Cramping at night, surprisingly, is like the second common one. Patients will come and say, I have cramping at night, wakes me up in the morning. I'm not drinking enough water. They always have a solution. They always say, doctor, don't worry about it. It's water. Or I got to eat more calcium, or, this or that. Or I'm not getting enough air. I always get up, go to the window. As soon as I open up the window, my cramps go away. And so that one, I got to be honest with you, I'm like 99%. If a patient comes with cramping, I get very excited because I always tell them, let's get them on the socks. I say, wear these socks before you come back. Tell me if you've ever had cramps again. Literally, the cramping goes away almost instantaneously as soon as you start wearing compression socks. So cramping, swelling is a big one. Swelling could be multifactorial. Multifactorial meaning that it could be due to veins or other problems.
And other problems.
Exactly. And there's a lot of problems that can cause swelling. Okay, so that's one of them. Itching. Okay, that's because of the skin. You're starting to get skin breakdown, losing the hair on the skin, so itching. Heaviness. I used to have like a rhythm going. Pain, swelling, itching, numbness, cramping, heaviness, and just uncomfortable feeling of your legs. And usually it's worse at the end of the day because you're standing or sitting all day.
Sounds like a rap song. But so there are a lot of symptoms, and people, though, get adjusted to them, don't they? So
they do.
When they come into Dr. Mencia, let's say, before he refers them, are you asking them all these questions, or you just can see things, or what?
Well, we ask, but sometimes they are so obvious that when you are examining the patient, you can see, you look at the legs, and you can see that. And I just saw one of my patients from Canada with bilateral leg edema and redness and most of the signs that we just mentioned. And, it's a lady, so she said, I'm not shaving that much. I just my leg a little bit now. And I said, well, I want you to get the compression stocking to take back with you to Canada. She said, no, I got 3 pairs already. I say, okay, then we need
wearing the machine.
Well, she does. She
does.
she took them off just to come and see me because it was her first visit. It was an emergency. And she came for something else. And I said, just in my review system where we go, we review all the organs and all other conditions and looking for preventive things that we can do for our patients. And, I say, okay, when you go back to Canada, tell them I want you to go and see a vein doctor. Okay, somebody that can treat your vein. You have venous insufficiency. Because she said she loved the stocking. She said, I put the stocking on and the swelling's still there, but at least I'm able to walk better and I feel better with my legs. I said, as soon as you go back and see a vein doctor, and you're going to get a lot better than what you're feeling because it was so obvious. And now this lady, you look at her leg, and you don't see those ugly varicose veins that we see sometimes. You can tell that those veins are more internal. So, if you can imagine the leg in a 3 dimension, some of the vein can be here on the surface, and some of them can be over here close to the bones. So that one are covered by muscles. And those are the big veins. Usually the bigger vein will tend to be closer to the center for protection, as well as the bigger arteries. Like your aorta is not on one side of your belly, it's in the middle of your belly. That's a big artery. So I say, you have venous insufficiency, have to be one of those internal veins. And she said, no, but my blood pressure is good. I said, I have nothing to do with your blood pressure. So we try to do with her a little bit of education,
But wait, just go back to that. So blood pressure is, as you said, arterial.
Arterial, right.
But the vein is venous, but it's pressure.
Correct. So you actually have
and
two
so
blood
one doesn't
pressures.
have anything to do with the other.
Well, you have two different flush pressures. You have when your heart is pumping, and you're measuring the blood pressure with the cuff. That's the arterial blood pressure. But when the blood is returning to your heart, you also have a pressure on the venous end. And so the pressures on the arterial side, like 180 over 20, so it's very high. But on the venous end, the pressures are very low, like 10 to 20. Right, so it's a very small change in pressure on the venous end makes a big difference. But we don't have a way of measuring the venous pressures. We would have to actually put a needle inside the vein and measure pressures that way.
Hold that thought because we're going to have to go to our break, and we'll be back.
Yes.
Thanks for listening to The Wonderful World of Wellness with Dr. Andy Mencia. Be sure to tune in each Saturday morning from 7 to 7:30 right here on WSBR 740 AM.